Welcome back, everyone, to another virtual shouting session at Hearts for Health. We're excited that y'all could join us. It's almost the end of June. That's pretty crazy to think about. But today we're joined by Dr. Reid. She'll be talking about psychiatry this session. And I don't think that's a topic we've seen very often or maybe even at all so far on virtual shouting. So it's very exciting to see that specialty today. Quick thing about Dr. Reid, just to give her a brief introduction, and I'm sure that she's going to talk a little more about herself later on, but a quick background about her. She is a double board certified psychiatrist in child and adolescent psychiatry, and then also adult psychiatry. Like I said, she'll probably talk more about this specialty and also herself. Quick few reminders, though, I did want to add in, especially if you're new to virtual shadowing or our program in general. So at the end of each of these sessions, today and also in the future, we always have a Q&A saved. So if you have any questions for Dr. Reid or any of our future speakers, please do type them in the chat. That should be either below or to the right of the live stream that you're viewing right now. And another thing is we do have our email listserv and our Instagram page as two platforms where you can stay tuned with more sessions that are to come. So these sessions are typically on Mondays and Thursdays at 7 p.m. Central. Timings do vary, and we do include those times and dates on our flyers, like I said, that are either on our email listserv or Instagram page. So the only reason I bring that up is for any of y'all that would like to stay tuned with more sessions, those are two great ways to go about it. To get added onto our email listserv, we have a subscription form at the very bottom of each of our website pages. So if you click onto our website, go down, scroll down all the way to the bottom, on the right hand or on the left hand side, you will see a subscription form. Fill that out with your name and email, and you're going to be good to go. We do recommend that you include a personal email. So that could be a Gmail, it could be a Yahoo email, just as a few examples. We just recommend to stay away from including a school email because sometimes our listserv might filter out to spam, so you might not be able to see it. But that listserv does include really the same flyers that you can expect to see on our Instagram page. So both are great options. There's no necessary preference for one or the other way in terms of staying tuned with sessions. And that's all I have to say. Later this summer, we will have a couple more opportunities introduced outside of virtual shadowing. Like many of y'all probably know, we do have a number of volunteering programs, I should say. And we also do have our mentorship program. So if you're interested in joining in any of those or multiple of those, we will have applications released later this summer towards late July to August. And you can look forward to that. Again, those are things that we will send out over our Instagram page and our email listserv. I don't want to take too much time with reminders, though. So if you have any questions about all that I talked about or anything outside of what I talked about, please do feel free to email us. We're happy to answer any questions. With that said, though, Dr. Reid, feel free to take it away.
All right. Thank you so much, Michael. And thank you for everyone for being here. And it's an honor to be here. And thanks for inviting me to talk. So I wanted to share a little bit more. I want to keep this interactive and keep it fun. And there's going to be opportunities at the end to ask questions and even throughout. So just to start, my name is Dana Reid. I'm a board certified child, adolescent, and adult psychiatrist. I'm in private practice in Alpharetta, Georgia. So let me go to the next. Oops. All right. So just a little bit more about me. Like I said, I'm child, adolescent, and adult psychiatrist. I started my private practice right after finishing fellowship at Emory. And this July will be 10 years of private practice. And also, in addition to that, I love speaking. I started I'm speaking like in conferences and also in high schools and different areas. Initially, some of my talks have been around like social media and how it impacts mental health of teens. And then it's kind of changed throughout. So I have a lot of interest and talk about a lot of different things. Also a mental health advocate. And I also started blogging a little bit and also have an Instagram page that I share a lot of mental health tips and information on there as well. One thing I added new to my title just this past February is that I wrote my first children's book about a little boy, kind of inspired by my 8-year-old son, about believing in yourself and not giving up. It's called Danny Doesn't Quit. So that's another additional. Okay. So a little bit more about my practice. So what I want to do is share a little bit more about like practice, the day in the life of a psychiatrist, a little bit more of the path to psychiatry. And then at the end, I'll share a couple of cases. So in my practice, I see children, teens, and adults. So ages like 6 to 65 is where I usually, and I do a variety of cases. So I treat ADHD, depression, anxiety, bipolar disorder, autism, eating disorders, and more. My interests, one thing I mean, I have varied interests and they change throughout. So I don't just focus on one area. So as I was in my fellowship and my training, I fell in love with college mental health. I worked in a couple of college counseling centers at Georgia State and Oxford at Emory. And I've been able to do that within my practice. So I see a lot of college students, and I love being able to follow them all from like high school and through college and even past graduation. The hard part is when they get jobs and then they move out of state, and then it's harder sometimes to be able to continue seeing them if they move out of state. And then also love working with adults and navigating like life changes, either as they're becoming parents themselves, becoming empty nesters, going through challenges, loss, divorce, work stress. And then I incorporate a lot of, in addition to prescribing medications, which I'll talk about, I also do a lot of therapy in my practice and love doing therapy with adults. I went to my residency was very heavy in therapy, and that was something I've continued through the years and I love doing in my practice. And I also put a lot of emphasis on other aspects that help people feel their best, including like emphasizing sleep, exercise, nutrition, and making sure they're also spending time with friends and engaging in like meaningful activities. So path to psychiatry. So I started with like a 4-year undergraduate degree. So my degree was in microbiology from the University of Georgia. And then I did take some time in a break. So I took a 3-year gap year, which I didn't put in there. And I worked as a microbiologist at the USDA as I was, working towards applying to medical school. And then I did my medical school at Edward Vyse, Virginia College of Osteopathic Medicine. There are different campuses now if you may be looking at medical schools or have seen, but I went to the Blacksburg, Virginia campus, which is affiliated with Virginia Tech. And then I did 3 years adult psychiatry residency at Baylor College of Medicine in Houston. And then I did my 2-year child and adolescent psychiatry fellowship at Emory. And then throughout that, there was the process of the boards just after residency, and then also licensing exams in medical school. And so why psychiatry? I get this question a lot. So I didn't go into medical school knowing I was going to do psychiatry. I actually thought all through my life I was going to go into pediatrics, and actually went into my first couple of years, went to pediatric conferences. And then it was maybe my 3rd year. I was actually on a pediatric rotation at that time. And I just remember, a case where someone was, getting sick often. And as I kind of dig deeper, I wanted to spend time. There was a lot personally going on in their life. This was a teenager, like with loss. And then I just started noticing, I just love being able to really spend time with my patients and to dig deeper and really understand what's going on in their lives and how that can be shaping like their journey or what's going on. And then I did a few electives in my 4th year of medical school in psychiatry, had amazing mentors. And that's how I knew psychiatry was my purpose at that point. So I love that you get to do the continuity of care, get to see patients from like when they're kids, teens, adults, and follow them through life, and get to the honor of like kind of walking along their journey with them. And one thing about psychiatry is it's never the same. You can have 2 people with depression, but they look completely different. And the treatment is very personalized and individualized. And the other thing about psychiatry that is appealing to a lot of people maybe looking into the field is you can do so much within the field. So usually you have a 3 to 4 year adult psychiatry residency program. And then you can do a fellowship in either child and adult psychiatry, geriatrics, addiction, college mental health, consult liaison, infant mental health. I don't know if there's a few other there's adding, and sometimes people do even like triple, like addiction and child and adult. You can work in an inpatient psychiatry setting, a hospital, general hospital as a consult psychiatrist, outpatient, whether it's private practice, community, a combination, intensive outpatient program, research, academic, college counseling center, nursing home. So the options are really endless, and a lot of people can do sometimes a combination of 2 or 3 different things. So a little bit more about the day in the life. So when I first started my, right after fellowship, I started my practice 2 to 3 days, and I also worked 2 days at a counseling center and 1 day at a community mental health clinic. At this point, I'm all 100% private practice, 5 days a week. Prior to COVID, it was all in-person appointments. Since then, there's been a huge desire, and a lot of people love the versatility and convenience of telehealth. So there has been a huge demand. So now I do 2 days, like Tuesdays and Thursdays, which are all virtual appointments, and then in the office Monday, Wednesdays, and some Fridays. So I start seeing patients. I wake up in the morning. Haven't been the best recently with working out, but I get up in the morning, usually around 5 o'clock, get a workout in, and then get kids ready for school, and then head to the office, try to get there between like 7:40, 7:45, and catch up on a few things in the morning. And I start seeing patients at 8 a.m. And then I see patients from like 8 to noon, an hour for lunch, which just also means like catching up on notes and other things, and then see patients again from 1 to 4:30. And then Fridays, just recently, I've changed my hours where I'm done at noon to allow opportunities for other things that's still within psychiatry, but not direct patient interactions. And then throughout the day, there's, refill, like medication refills, letters, notes, collaboration with others, therapists, treatment teams, reviewing records. So there's a lot that in addition needs to be done, but I try to either sometimes do it first thing in the morning, at the end of the day, or if there's some, pockets of time or holes throughout the day. And like I said, I love blogging, writing, content, social media, but I wish I had more time for it, because right now that's usually done in the evenings or weekends. And that's where I opened up some Fridays to have the ability to do that. And I wanted to kind of do, getting involved a little more with like the local medical school and as well. So that is all right. So any questions before I start talking about cases in terms of like the path of psychiatry, how I decided on psychiatry, anything else about medical school that anyone wants to ask before we start talking about cases?
Maybe we can add one more question or one question just quick before you move on to cases. So you mentioned that you were double board certified, or double fellowship trained, I should say, in child and adolescent psychiatry. That's one. And then adult psychiatry. That's the second. Are there any other subspecialties beyond psychiatry outside of those?
In addition to for psychiatry subspecialties?
Yeah.
Yes. Yes. So I'll just go back real quick to the slide. Yes, there are, and then they may be adding more. So there's definitely geriatrics. So that would be, you do like a 4-year, I think, adult psychiatry, and then the geriatrics fellowship, which I'm not sure if it's like 2 years. Don't quote me on like how long that, I think it may be like a 2-year fellowship. Another thought is like people do like adult psychiatry. So in general, adult psychiatry is 4 years. Child psychiatry is the one fellowship where you can fast track, where if you know for sure you're going to do child psychiatry, you can do the adult in 3 years, and then you go straight into 2-year fellowship. So you're doing it combined in 5 years. Everything else is like 4 years of adults, and then you add on like a consult liaison, like fellowship or addiction fellowship. There's a college mental health fellowship. I think there's an infant mental health. I know every now and then they add some more. I don't think like there's a sports psychiatry, but there are subspecialties. And then there's also other ways to get more experience and to do, but college mental health is there are some universities that have a college mental health fellowship. But the most common ones are addiction, child and adolescent, geriatrics. And there's also community. I think that was the other one I didn't mention here, community mental health fellowship as well.
Okay, thank you.
Any other questions?
I think that's all for now.
Okay, so I'll go through a couple cases, and I just wanted to say before I even start the cases, none of these are real patients. There's no identifiable information at all. These are just common cases that I see and just information but put together, but none of this is a real patient information, just to add that first. Okay, so for first case is, this is a 30-year-old male who comes in for a new patient evaluation or appointment. Talks about, I just don't feel like myself. I just feel tired all the time. I have low motivation. It's just so difficult to kind of do anything. I get out of bed and I just want to sit there the whole time. Things I used to enjoy, like spending time with friends or working out, I just don't enjoy it anymore. And I just feel like I have this like brain fog. It's just so hard to concentrate. Low energy, just tired all the time. I kind of wake up feeling tired, like I'm always dragging throughout the day. I also kind of noticed that he kind of feels more irritable, more easily annoyed, and don't kind of like that feeling. And then other people around him close to him kind of picking out, like, I feel like my friends and wife are worried about me because I keep canceling plans with my friends, or I just feel kind of apathetic and I want to just be left alone, which is not who I am. I want to kind of, complain about wanting to enjoy things again, like lost interest in things like reading, playing the guitar, tossing and turning. It can take a long time to fall asleep. And then on top of it, when it kept progressing, it's this feeling of just feeling hopeless, discouraged, and frustrated with this feeling, worry about, will I ever feel good again? When you ask about how long he's been feeling this way, it's probably for the past 6 months, but more days than not, just feeling down, and especially for like weeks at a time. Like any changes or stressors, like life changes, whether it's job or a relationship or anything with family. No, it's just some work stress. And it's a little more stressful at work, but other than that, not any big changes. So when I get a case like this, the first thing I want to do is really spend time like digging deeper and getting like a current history and then also past history. So getting a sense, have there been prior episodes of this? Is this something he's experienced on and off, like as a child throughout year, or is this just completely new only in the last 6 months? Has there been like prior episodes of like depression, anxiety, mood disorders? Like I said, any big changes, like did this come on subtly or was it gradually through? Is it any like seasonal changes? Any family psychiatric history? Is there a history of anxiety, depression in the family? And then any new medical issues or concerns, because he's complaining a lot of like physical symptoms of just feeling tired and can't concentrate and sleep feels off. So is there any physical symptoms going on? Any questions before I go ask what else you might want to ask? Or
Well, this question is on another topic outside of the case, but a student here asks, why did you choose DO instead of MD?
Okay. So do you want me to answer that now or keep that to the end?
Either one. I mean, if either order.
Yeah. So when I was looking at medical schools with DO track, I wanted to, spend so much time looking at even like as I was picking, I knew psychiatry wasn't until later, but looking at a whole person and looking at all the different things that are involved, and then looking at his person at home. And when I went and looked at VCOM, the medical school I went to, I just fell in love with it and just loved their approach and looking. And that's where I practice so much of psychiatry now, is that in addition to like medications and therapy, I spend so much time looking at what else is really going on and how do we address things in terms of sleep, nutrition. So it's a whole approach.
That's all for now in terms of questions.
Okay. So other thing in terms of further assessment, more detailed clinical evaluation by asking more questions about anxiety and depression. So if my thought is like, okay, maybe possibly he may just be describing depression. And the reason I think that at the top of my head now is that he's coming to a psychiatrist. So possibly maybe medical issues have been rolled out, or kind of feeling maybe that there is some feeling of depression. When I try to get people not say, have you been feeling depressed, but ask them, like, try to describe exactly what you're feeling and try to get it in their own words. Because I don't want to put words in their mouth or say like, you are feeling depressed, but get us like, explain to me what you're feeling. And then if they say I've been feeling depressed, I'm like, what does depression mean to you or look like to you? And because, depression looks different for everyone. So depression is not just feeling sad and moping around, but it could look very different, which I'll go through in a minute. There's also a really good quick questionnaire that you can find online called the PHQ-9 Depression Questionnaire. And it asks questions about depression of how you felt in the last 2 weeks. And then it's hard to pull it up right now with the screen sharing, but some of the questions, it's not at all, some days, like several days, more than half the day, or I think all the time or every day. So, and after that, you kind of score it. So you get a sense of like the severity of the depression that someone may be going through. In addition, a lot of times like depression and anxiety can go hand in hand for a lot of people. So I also, if I get a sense from evaluation, there might be some anxiety. I also do like a GAD-7, which is an anxiety questionnaire, similar, types of questions in terms of like sometimes more than several days, more than half the day, but those are specific questions for anxiety. So I don't base everything on that questionnaire, but I just think of it as an additional tool. So other things as we're thinking about depression, but some of it, I don't necessarily get labs on everyone. I think I look at the whole entire picture and get a sense of what's really going on, but these are some labs and some medical things that can look like depression. So B12, if B12 levels are low, people can feel very, very tired, fatigue, and it can look like depression. Vitamin D, you'll be surprised how like many of us are walking around with very low vitamin D levels. So even when I had mine checked, it was really low. And once people, add vitamin D or they get their levels back up, they can feel better. Not that it might fully address the depression, but you want to address that too, to see how much that may be contributing. Thyroid, a lot of times people may either have hypothyroidism or hyperthyroidism, and it's not really being addressed. And then checking the CBC to see could they be anemic, that could be explaining sometimes the tired. I know it sounds like he talked a lot about sleep habits and feeling tired all the time. So kind of exploring a little bit more about the sleep. Have there been sleep problems for a long time? Was there ever a sleep study? Did ever, people bring up some things that may look like snoring or falling asleep throughout the day, and exploring that a little bit more. And then are there any kind of new medical concerns or new medications that are causing him to kind of feel more like foggy or affecting concentration? And then nutrition and exercise, like I think we notice sometimes, like if we go too long without exercising or not eating healthy or not staying hydrated, we don't feel our best. And then also asking about like caffeine, alcohol, drug use, or vaping, because that all can impact mood and can also look like depression. Okay, so we got the labs all come back looking normal. So we talk about like the struggle with sleep, exercise, nutrition, but it feels like it's really been part of the depression, where I was feeling good before, but once I started feeling depressed, then I stopped exercising and eating healthy, and that got the cycle. And I always think about like a cycle of depression and inactivity. So what happens a lot of times when people are feeling depressed, it's really hard to do things that help you feel good. It's hard to kind of get up. It's hard to exercise. It's hard to spend time with friends. It's hard to eat healthy. And then that keeps that vicious cycle going. So if you're not taking care of yourself because doing those things that help you feel good, then it keeps that. Or if you're laying in bed all day, you're more likely to kind of feel foggy and tired. No drugs, no supplements. The only medication is like Pepcid, but he's been on it for years. This was prior to the depression. And then Zyrtec every now and then for allergies, but there's no correlation with the Zyrtec making any of these symptoms worse. So any questions at this point about the case? Okay. And so this is a mnemonic, an easy way to look at some of the symptoms of depression. It's called like SIGI caps. I don't know if any of you learned this so far, heard of it? Okay. So it's the SIGI caps. So S stands for sleep. So a lot of times when people are going through the depression, they might end up sleeping too much or sleeping too little. They may have loss of like interesting things that they used to enjoy doing, sometimes feelings of guilt, low energy, like that affects their concentration. I think concentration is what low appetite, or sometimes they eat more, just kind of feel like this retardation really slowed down, and they may have suicidal thoughts. For major depressive disorder, you usually need like 4 or more of this criteria. And then there's also persistent depression, which is still depression, but it's like this level of depression that seems like a little bit lower, but it's just consistent for like days and can last up to like years. And then sometimes people can have what's called a double depression, where there's like this low level depression that's always there and persistent. And then on top of it, they have a major depression episode where it's very significant and continuous on top of the depression that's persistent. So when I think about, okay, so based on this case, I was going to say like he has a major depressive disorder, and I'm just going to say that it's a single episode. This is new, hasn't been there before. There was like a family history of depression, and then there's also just more work stress that could have been, brought on some more of the depression. So the next thing is, how do we address it? I always look at not just one strategy, but a combination. So therapy, and that could be like talk therapy, cognitive behavioral therapy. I always talk about behavioral activation, where, like I said, it's really hard for people when they're feeling depressed to want to do things, but to start with, let's put a few meaningful things in your day. Why don't you start with like a 20-minute walk to get outside? Like, where can you meet them where they feel like they can, like, to tell someone sometimes to go to the gym 7 days a week for an hour, that they're going to shut that down, right? It's not really, but if you just say, okay, let's just sit outside for 20 minutes, get fresh air. Or why don't you meet a friend for a walk? So starting with small things that can be meaningful to them and whatever like their hobbies are, and let's just start slow and slowly build up. So kind of meeting them where they are. And then if you plan those things and slowly add up, and even just like when you wake up, don't go back to sleep, don't go back to your room. So just small things to kind of help you feel better. And then that kind of gets those habits back. Medications can be very effective for depression in combination with therapy. There's SSRIs, SNRIs, different types of medication. I actually didn't mention it here, but there's also TNS, like TMS, transcranial magnetic stimulation, which is also non-invasive form of treatment for depression. There's sleep, exercise, nutrition, putting meaningful things in your day, social connection, and then also like a gratitude practice can help. Any questions? All right. So another clinical pearl I want to say, a lot of times for kids and teens, irritability, agitation, and anger is kind of a symptom of depression that a lot of times we might not think of with depression, but a lot of teens, which I just feel like just irritable, just annoyed, like I'm short-tempered, and sometimes we see that as well in some males. So that's just something to pay attention. So depression, like I said, can look different for everyone. All right, second case. So like I said, these are not real cases. It's a 16-year-old female. She comes in for initial evaluation for concerns of feeling worried and anxious. Adjusting to high school has been challenging, especially everything after COVID and getting back. Some of her friends that she's known through the years have kind of turned their back against her, stopped talking to her, just kind of feels alone. What's the point of making friends? They're just going to betray me, reject me. It's hard to trust people. After school, the past, she'd kind of go and play soccer, but now comes home and she just snaps and goes straight to her room, not even necessarily on Netflix or communicating with friends through text. It's just going and just laying there in the bed and sometimes napping. Parents say like she's in her room all the time now, stop playing sports because what's the point? I'm not good at this anymore. And then also on top of it, there's a lot of like physical complaints, like stomach aches, headaches. I wake up feeling nauseous. And then there's a lot of missing school because just feeling physically, it's really hard to go when I'm going to get sick, or if I go to school, I'm not going to feel good. And then feeling tired often and just mentally drained, worrying about almost everything, a lot of what if scenarios. What if I'm not good at this? What if people don't like me? What about my future? Is everyone's better at things than me? And then moms keep saying like, I keep getting texts from her at school to pick her up. And there's overthinking everything. Like I said, this constant feeling of just waking up in the morning, feeling anxious, also describes like feeling on edge all the time and takes a long time to fall asleep and goes over things in our head and hard to just relax. And then when I'm like, okay, how does anxiety get in the way of things, or how does it cause problems? Well, I try to spend time with friends, but I'm not really there. I'm there, but I'm not there because I'm just mentally exhausted. I'm worrying or what I sound or what they think, or so like physically not even kind of engaged with friends. And then parents always say, like, I feel like I'm having to walk on eggshells around her. I don't know what kind of mood she's going to be in. She's kind of irritable and more easily annoyed, which is not her in general. And they say this is not just her being a teenager, like this is out of the norm of how things have normally been for her. So I think similar to the last case, you really want to dig deeper and try to get a history. And usually since she's 16, you want to get a good history from both like her and then also from the parents, and then trying to see, can you also get a history from like, what are her friends saying? Like are people reaching out to the parents saying like, we're worried about your daughter, or we're seeing this? Are there concerns from teachers, coaches? Any big changes with friends or school? Are there any kind of concerning texts that parents are finding, or any changes in behavior, any bullying, any trauma? How are social interactions? And then on top of it, we want to get a past history about childhood anxiety. Is this someone who's always been anxious or had problems with anxiety, or is this new? Any concerns for like focus, attention, any history of ADHD, depression, other fears or phobias? And then also looking to see, are there any medical concerns, caffeine, drugs, vaping? And then I would still like there's the GAD questionnaire, which we talked about for anxiety. And there's also a more detailed one called the SCARED that you can find online. And it's the parent version and the child version. And there's like over 30 questions, and it's detailed, and it can help narrow to look at, there's some questions that are more specific for social anxiety, for generalized anxiety, panic disorder, or school refusal. So it gives you a sense of, and you get the perspective from both the parents and the kid. And then also looking at observations, like I said, from teachers or other family members or coaches. As much information as you can gather for a teen, it's very helpful to kind of just notice the different perspectives. All right, so did I do the labs? Okay, so I think similar, you can also get some labs, but the labs will look different. I think for thyroid, if there's hyperthyroidism, it can look like anxiety, and also can check like vitamin D levels as well. Trying to think. So I think that's medical concerns, the vaping. Okay, and I think with this, like, someone said, okay, well, they saw, their pediatrician, they saw their gastroenterologist because there were a lot of physical symptoms. All the workup that was done by their pediatrician was negative. There was no concern. So despite the physical symptoms, and also the pediatrician has suggested that this could be anxiety, and that's how they were referred to a psychiatrist to evaluate that. So based on everything, looks more like a generalized anxiety disorder, but there are other anxiety disorders, and some of the more common ones I see are the generalized anxiety and social anxiety, and then OCD. There's also panic disorder as well. And then the treatment would also be therapy to start with, like cognitive behavioral therapy, also exposure therapy to help with OCD and social anxiety, but you start gradually. So if someone is having anxiety about, if I go and spend time with friends, or I go to a party, I'm always worried, like, they're going to judge me, or I'm going to embarrass myself, or I'm going to say something stupid. But the more you avoid that situation, it doesn't help. So the key is to put yourself in situations that are uncomfortable, but to do it small. So maybe starting with, go to a party with a friend. Maybe go with a plan, you're going to stay there for 10, 20 minutes. And if you don't feel comfortable, you can leave. So the more you put those things in place and have exposure therapies, people feel better. But a lot of times with anxiety, the tendency is to kind of want to avoid anything that's very uncomfortable. And then that creates that cycle. And sometimes avoidance can look like a lot of things. Sometimes people come home and they just snap because everything else seems so exhausting. So that can be a form of avoidance, or just like mindlessly scrolling their phone or not socializing. Those are all parts of avoidance. Medications, SSRIs are very effective, like Zoloft, Lexapro, Prozac. There's also SNRIs like Pristiq, Cymbalta, Buspar. Also, magnesium is an over-the-counter supplement that can help with people feeling more calm and help with sleep and anxiety. So that's also something that can be started. L-theanine is also a supplement, and N-acetylcysteine NAC is also another supplement that can help with OCD and anxiety. And then of course you want to address certain things. Like sometimes people are like, okay, I'm anxious all the time, but then you talk to them and you realize they're drinking 1 or 2 Celsius a day. So I don't know if anyone's had Celsius, but you can feel very, very jittery and anxious on that, or like 4 or 5 cups of coffee. So really asking them too, like, are you having energy drinks? What's your diet like? Are you, staying hydrated? Are you making sure you're eating? Because there's a lot of things that you can hear, or they're on, not going to bed until 2 o'clock in the morning on their screens right before bed, which we're all guilty of. And then you just feel tired the next day, and it keeps that cycle going. So I think looking to see what are other habits in their day that could be making things worse. All right, so this is what I have. I thought I would open up for questions and any opportunities, whether it's related to the cases, not related to the cases, about path, psychiatry, medical school. I'm here for the questions.
Well, first of all, thank you so much, Dr. Reid, for getting this presentation together. We always love to see cases. And like I said, I think it has been probably the first time we've seen psychiatry on virtual shadowing, or at least the subspecialties for it. So it's always great to hear. And I'll start it off with a question, but while I do, for those listening, feel free to type in your questions, because we'll be rounding out the hour with this Q&A. So we'll have the next 20 minutes dedicated to it. But just to start us off, I wanted to ask, what's the biggest difference you see between pediatric patients and adult patients?
Biggest difference. Trying to think about the question. You mean, so like with teens and kids versus
Yeah. So for example, maybe the way that they respond to certain just the treatments that you give, or to recommendations you give, or maybe it might be, I guess this is maybe more applicable to, it could be more applicable to them in general, not necessarily specific to the specialty. Maybe the way that you approach them, your bedside manner with them.
okay.
Either
Okay.
one, if you want
Yeah,
to.
so I'll try to answer both. I think that one of the main differences, as you might realize, is that with an adult, you're only working directly with the adult. With the kid, you're working within like a family system. So you really have to build a relationship with both like the parent or parents, and then also the kid, and establish trust with both of them. A lot of times, if a teen or kid feels like they're not being heard, or that you're talking directly to the parent, then you can lose that trust. So establishing trust with a teen, a lot of times it's like, I want to hear more from you, and really want to hear their perspective, so it doesn't feel like it's being clouded by the parent. But at the same time, you have to get both perspectives, because you can be definitely missing detail if you only get one perspective. And sometimes people are all on the same page, or sometimes not. Even sometimes I think some of us, we might not be aware of what we're going through, our actions. And sometimes when you have another person seeing it, you realize, oh yeah, I actually do that, or that makes sense. So I think part of it's like you're treating not just the individual, but you're treating the whole family in a sense. And then also building that rapport. And a lot of teens worry, or kids, that if I say something in here, will it get back to my parent? So kind of building that confidentiality, but of course you still have to develop a relationship with the family. So it's a fine line between, I want to do what's right, and I have to include your family, but also keeping, like building that trust and confidentiality with the teen. The other thing too, sometimes they have different opinions. So sometimes a team might say, okay, this is what I really feel is going on, or I feel like I want medication, the parent may not be on board, or the other way around. So I think just goes back to kind of building that trust. And then I think the other thing in terms of like treatment, sometimes for some teens, not all, or some kids, they might be open to like therapy, they may not. So or they might be doing it because the parents telling them to, so really to kind of get their buy-in and explain things, and like, to build that rapport and comfort. Like, this is why we're doing this. This is what it's going to help. Things like that as well.
Earlier on, you mentioned that you work in private practice. Was there anything particular to that type of setting that drew you to it?
Yes. So one thing I loved college mental health, but I also wanted to see variety. Like when I was working in the college mental health, and if that I made that a full-time career, I would miss opportunities of like working with younger kids and teens and also working with adults. I kind of like that diversity of working with all ages. The other thing about private practice is that I feel like I can tailor, in a sense, someone's treatment plan to how it wants to be. So in private practice, there's that autonomy of saying, if someone wants to come back every week, or I feel like they need to come back in 2 weeks, with owning the practice and being able to be flexible, like I allow a lot of time to see my patients, like 30-minute for follow-ups and more. And sometimes we can do an hour, I can do therapy. So it allows a lot of flexibility of designing your practice and treatment on what you think is best for the patients. It can be very individualized. I do therapy, I spend time. There's not a thought like I can't see you back for 3 months or some 2 months. There's allows the flexibility of being able to see people as often as they want or need sometimes.
What was the biggest challenge that you faced during either residency or fellowship?
I think in residency, it was definitely the hours, so it's definitely gruesome. I remember in my first couple years were good. I think adjusting to like call and long nights, and then the sleep deprivation was really hard. And I remember in my second year, as I was deciding whether I was going to do child or I wanted to do child, but I remember at one time, like you come home at 2 o'clock in the morning from being in the emergency room and doing admission, and then you get ready to get a few hours of sleep before coming back at 7 o'clock in the morning. There was one time I get called back in at 5 o'clock. You lay down for an hour or two, that you're called right back in. So it's like having to keep that those long hours and the challenges with residency. I think residency was more challenging than fellowship, because residency there was a lot more call and longer hours. With fellowship, our call was, a lot of it was home call, and the call was pretty reasonable, so it didn't seem as hard.
During COVID, during the pandemic, just 3 years ago, did you notice that using platforms like telehealth still allowed for the same improvements that you saw in patients after, one appointment to the other through the weeks?
Yeah. So one thing, that has come out of COVID that's been good is that, the adoption of telepsychiatry. I remember a while back thinking about, should I establish that for some patients? So I have some of my teens, they go to college within the state, Georgia, but I can only see them over breaks or summers when they're home, because it's hard for them, even if it's local, to drive to college. So that was something I had considered before, but I was surprised about how effective telepsychiatry was and how convenient it was for people and how much people love it. I will say, now that I'm having people come back to the office and wanting them to come back in the office, sometimes you can, for some people, miss some intricacy, like body language, or some things can, it's better to have some of that in person, even if they come in once every few months in person, and you still maintain that telepsychiatry. So it's definitely been a lot more effective than I thought, because even when I see people and then it's 2 years later they come in person, it's hard to get people now to come in person because they've gotten so used to and love telehealth. Like, oh, it doesn't feel like it's been 2 or 3 years. And that speaks to how you can still build that relationship and rapport through telepsychiatry.
Definitely. You also wrote your own children's book. What was the inspiration behind that, and what was the process of actually writing it?
Okay. I actually have the book here. I can show. Here. All right. So here's the book. It's called Danny Doesn't Quit. And the inspiration is actually inspired by my 8-year-old son. So anytime something felt really difficult for him, he wanted to quit, and he would say things are really hard. And anytime we tried something, he was just like, I'm not doing this again. And there were tears. But once he decided to start baseball, he went out there, and there were so many kids, or most of the kids were actually better than him, but he kept going and trying. And it was during an important playoff game, he made a really great hit after 2 strikes in his last one. And that's when I realized, like, wow, how powerful is that if you really believe in yourself and believe that you can do hard things and don't give up, and you see the process through, like what's possible. And it's not just for kids. I also see it for us as adults. Even I'm like learning tennis now. And I remember when I first started, I couldn't even like serve the ball and I wanted to kind of give up. But when you keep believing in yourself and seeing things through, and doesn't necessarily mean that you're going to be the best at something. And he's not, and baseball may not be his sport, but it's just seeing him through. So it's the message about you believe in yourself, you persevere, and not giving up. That doesn't mean that you stay with something if you don't enjoy or it's the right fit, but it's more about the mindset of not giving up.
100% persistence, just like we have here with medicine, right? Going through all the years of training. Another question we have is about the specialties you were interested in. So you mentioned in the beginning that pediatrics caught your eye, and then after a patient encounter, you fell in love with psychiatry. Outside of those two specialties, were there any other specialties that you considered, any surgical specialties?
Yes. So I actually loved my surgery rotation, and the surgeon I worked with, he was phenomenal and really, really nice, and was trying to tell me to go to surgery, but I was like, I think it required so much like attention to like the detail, and in such a way that I love like talking to people and listening. So it wasn't this necessarily the specialty for me, but the three that I was between was pediatrics, family medicine, and psychiatry. And I feel the three of them have certain things in common. What drove me to all three to consider is that the continuity of care and developing like this relationship with a patient. Seeing like patients like through a lifetime, like with family medicine, you can follow them from like their kids, teens, adults, see their kids. So that's what drove me to those fields. I was more interested in fields where I can have that continued care. And that's the reason for psychiatry. I like the private practice for outpatient as opposed to like inpatient or ER psychiatry, because you get to see and follow patients along their journey.
And we know there's quite a few types of disorders in psychiatry. You mentioned a couple like anxiety disorders, generalized anxiety disorder, social anxiety, panic disorder, all of those. If you wouldn't mind just kind of going through those general types that that you see. So anxiety disorders, eating disorders, I'm sure there's a couple more, not necessarily all of them, but just kind of a brief run through so students can get familiarized with terms that they might hear if they were to shadow in person in psychiatry.
Okay. So going through like the criteria, or just what it just overall looks like, maybe
a description of what they look like.
Okay.
So, yeah.
So I'll go through the more some of the more common ones that you'll probably hear or see on a daily basis. ADHD is one that you probably all heard about or seen, and especially if you're on TikTok or Instagram. And it's one of my favorite things to treat and to talk about. I can talk about ADHD. So ADHD is it sort of that you see that it starts in childhood and it goes throughout a lifetime, and it's not just someone not being able to focus, but it affects everyone in terms of like social relationships, like social and organization and executive function. So it's harder time like planning, starting things, following through with things. It can affect like regulating like emotions and frustrations and the overwhelm. And a lot of times when someone has ADHD, they can get really overwhelmed with multiple things and not knowing like how to start, how to follow through. And a lot of times it becomes more noticeable or starts really getting in the way of life for people when they're in, high school or college. And some people can go undiagnosed until they're like in their 30s or 40s. And it's pretty common for a lot of women to not get diagnosed until their 30s or the 40s, because it can show up or look different for girls and boys. Like for boys, you might see it in the classroom, someone who's like blurting out or jumping up, down, or that hyperactivity and impulse. But for girls in the classroom, when they're younger, it might seem as like daydreaming, like more not turning in assignments or talking a lot in class. So that is one thing that's common, the ADHD, both in kids and teens and adults. Treatment's very, very effective. It's a combination of like medication and then also behavioral strategies can help as well. Any questions about ADHD?
No, not in particular.
Okay. And then depression. And for depression, like I said, like there's major depression, which is the case I gave. There's also persistent depression where the one thing about all of the diagnosis that we think it starts becoming a diagnosis when it starts affecting functioning. So we all have days that we feel anxious or we feel sad, but when it's persistent, it's there more days than not. It starts affecting like our functioning, our quality of life. That's when it starts becoming more of something that needs to be addressed. So I mean, you have a kid, like they're anxious about certain things, trying new things before a test, but it's really more when there's like this persistent anxiety, like where they're having stomach aches, they're having headaches, they can't sleep, they're going to school, they're crying, it's getting in the way of socializing. So for the anxiety, you can see in kids, teens, adults, generalized anxiety is when there tends to be an anxiety about most things or everything. So it's not a specific anxiety about falling asleep, or it's not a specific anxiety about thunderstorms or about school. It's a generalized worry about everything. Like, is my mom going to be okay? My mom's late and I didn't get a text back. Am I going to fail this test? Am I good enough? So it's a generalized worry about a lot of things where it starts impacting functioning. OCD is when there is this, you can have like intrusive thoughts with OCD. Like if I don't do this, something bad's going to happen, or I have to count to 3 or do something very specific or a certain number of times, or if not, this is going to happen. So these intrusive thoughts can be very, very debilitating for people because they don't want to feel this way, but it's like a severe kind of anxiety where they ruminate on it and then they have to act on certain rituals or compulsions. I'm trying to think which other ones. The eating disorders, there can be binge eating disorder, there's disordered eating, there's anorexia. I think about other ones to cover. I don't want to like give too much information.
Absolutely. Well, there is one I wanted to ask about in specific, and this might not necessarily be a category per se, but it definitely is a condition that I'm sure many of us have heard about, and it's postpartum depression. So how do you typically go about considering treatment for it? I know this is going to be unique from patient to patient, but as a general consensus, do you feel like it requires medications? Because I know that it's due to the hormone levels that are changing postpartum, or is it more so therapy that you often side with?
Yeah, so for postpartum depression, if I am seeing someone and they become pregnant, then if they're currently on medications, you want to look at what medications they're on and safety, but in general, you always want to look at if this is not their first baby and they've had a pregnancy before, how was that pregnancy and how was that postpartum period for them? So if they've had postpartum depression before, and we know like depression, when they have it, it's really not good. You want to maintain them all throughout their pregnancy and make sure that their depression is being managed, because that can help with like postpartum depression or prevent it. If this is someone who's like never had problems with depression before, you're following all of them throughout the pregnancy, there's no problems with depression, postpartum period, they do need to kind of be seen, with their OB. But I think a lot of it's going to be education for people. Like if you're feeling this way, like how do you make sure like they're recognizing and getting the help right away? And postpartum depression is something that can't be waited on. It has to really be treated. And there's like a spectrum of it. It might be mild where like therapy and might be enough, but it has to be like keeping a close eye on. If there's any postpartum psychosis, that's an absolute medical emergency. People have to be hospitalized for that. So I think to answer that, you have to kind of look at what is their history of depression before, how is it throughout the pregnancy, and how do they do when they've delivered in the past.
And one more question just to wrap up the hour, and that's going to be about, as a psychiatrist, do you refer patients to psychologists? And if so, what considerations go into that?
Okay, yeah. So I definitely refer a lot to psychologists. Like I said, I love doing therapy, but with like the time limitations and also my area of specialty, I tend to do therapy if people want it with with adults more and young adults. A lot of times when I get referrals, majority of the time, they're either coming to me either from a pediatrician or an internal medicine doctor or family medicine doctor, or a lot of times they're coming from a psychologist. So if they're coming from a psychologist, they already have a psychologist. I'm also like collaborate and work with them. So I will do them like medication, some brief supportive therapy, and they have a psychologist they're seeing. If I'm seeing a teen with anxiety or OCD, and I feel like I'll help with like do the medication aspects, and then also help with some supportive therapy, but they really need therapy, then I will look at, get to know the patient. And then I have a network of several like local psychologists and look to see based on location, who would be a good fit, what is their area of specialty, I would refer to them. So and we collaborate a lot with psychologists. So the majority of the time I'm not actually doing the therapy for the kids and teens, but they're working with a psychologist.
All right, well, that's going to wrap up today's session. Thank you again so much, Dr. Reid, for getting this presentation together and for going through these questions. There were quite a few that we had, and I definitely learned quite a bit. I'm sure a lot of students did too. I do have one last reminder before we do close out. This is going to be for the students listening in, especially if you are interested in earning credit for your attendance today. So we do have a certification system. If you're new to our virtual shouting program, we do have a certification system for y'all to earn shouting credit for attending today. And we have a quiz. That quiz is just a Google form with 10 questions. You have to have 6 or more correct in order to pass. And once you do pass, we will send you a certificate through the email address that you list on the quiz. Please just make sure that it is a personal email. It's just helpful that way, although it's not necessarily required, just a suggestion. Quiz will be due on this Sunday, July 2nd, 11:59 p.m. Central Standard Time. So just be sure to get it done before then. I've posted it in the chat. I've also posted it on our video description and also on our website. So any of those 3 places, you'll be directed to the same form. If you'd like to go through our website, we have it on our virtual shouting page. If you scroll just a bit down, you'll see a Monday and a Thursday quiz. Click onto the Monday quiz. Like I said, you'll be directed onto the Google form. If you have any trouble with receiving your certificate, please do check your spam folder. And if you don't happen to see it in your spam folder, please do send us an email and we can help track it down. And then as for our next shadowing session, we will have quite a few PAs coming up these upcoming weeks. So if you are interested in seeing PA speakers, this is the time for you. Next, we'll have Saif. He is an emergency medicine PA from Canada, and he currently does practice in Ontario, I believe. So we will see him on July 3rd. That will be, I believe, oh, sorry, wait, I just got ahead of myself. So we'll see McKenna. She's a PA in emergency medicine. That will be this Thursday, June 29th. And then we'll see Saif next Monday, again in emergency medicine, again a PA, but 2 different speakers we'll have. Again, if you're interested in seeing PAs, we have quite a few going up through around middle of July. So from there, from now until then, you can look forward to those speakers. And let us know if you have any questions. We do have our future speakers featured on our virtual shouting page if you'd like to take a look. But outside of that, the only last reminder I'd like to add is if you missed what I said earlier, we do have our email listserv and our Instagram page for y'all to get caught up with anything to do with our shouting program and our other volunteering/mentorship program. So definitely feel free to give us a follow or subscribe and you'll be in the loop. But that's all for today's session. If we can hear some thank yous in the chat for Dr. Reid for getting this presentation together. I really do appreciate your time, Dr. Reid. Thank you again. It was really an honor hearing from you.
Yes, well, thank you very, very much. Thank you for the opportunity, and it's been an honor to be here. And then if anyone wants to, as you're going through the process of applying to medical school or even just, pre-health and other questions you have, feel free to reach out. I remember the process. I wish I had like this opportunity when I was going through the process. And you can find me on Instagram at Dr. Dana Reid. You can feel free to send me a DM message, and I'm happy to kind of help throughout the process. Good luck to everyone. Thanks again for having me.
100%. Give Dr. Reid a follow. She has great content on her Instagram page, and definitely take advantage if you can with her offer for help. I mean, it's always great to hear from a professional who's all the way into practice. So that's very, very beneficial, especially because I know a lot of y'all are right now in the application cycle. Summer is usually a time to relax, but for those who are in the application cycle, we're wishing the best of luck. Y'all need all the help you can get. But
And then I'll just say one thing. I will say the hardest part of the whole journey, when you asked about residency and fellowship, it was the process of getting into medical school. And that was probably the hardest. So I don't want anyone to kind of feel discouraged. If I would go over and do it again, it would be 100% yes. But yes, there have been rejections. There have been applying again. It's not an easy process for some, but it's worth it. So I just want to give that big of encouragement, is because I know sometimes it can feel very discouraging.
Yep, we appreciate it. Well, I hope you all enjoy the rest of your night, and we'll see you on Thursday.